Good morning, everyone. Nice to see you all after a long time, nearly 2 years. This first session is going to be on superficial venous diseases. I would like to call Dr. Shahab Padaria to talk about advancing laser ablation. This gentleman, no need to introduce Shahab, everybody knows him.
Let me thank Dr. Deepak, Dr. Vimalan, the entire organizing team for Vicon for putting up this lovely show in spite of the pandemic. Great venue, and I think great arrangements. Thank you very much. So let me take my guard as first batsman, and let me start with the talk. What I'm going to speak today is on advancement of lasers and the 1940 laser, and what exactly is the 1940 laser. So we all know that the original work on EVLA was performed using a diode laser, which was the 810 and 980 nanomicron laser many, many years ago, more than 25 years ago. And over a period of time, we have realized that clinical studies have shown that endovenous laser with a laser emitting wavelengths at 810 to 980 nanomicrons, bare fiber application can cause perforation. We've seen that in our studies, in our clinical practice, and along with that, there's also increase in pain, ecchymosis, and nerve damage occasionally. Now, analysis of the absorption spectrum of water reveals that wavelengths, which are larger than 1300 nanomicrons, show a higher absorption coefficient in water and reduced hemoglobin absorption. This is common knowledge. Further analysis of this absorption spectrum of the coefficient in water beyond 1470 nanomicrons has now revealed a second local absorption spectrum of around 1940 nanomicrons, with the absorption coefficient in water for 1940 being much greater than that of 980 or 1470. And as you will see from the penetration characteristics here in this graph, the penetration with the 1470 is much lesser with that of the 980, and that of the 1940 even lesser than that. So over a period of time, there has been an evolution from 980 to 1470. Today, I believe almost all of us are using the 1470. And we know that as far as the 1470 nanomicron is concerned, there's 40 times higher absorption in water than the 980. But when we talk of the 1940 nanomicron wavelength, it's 40 times higher than the 1470. So we've come a long way. But what we need to do is, does this really benefit our patients? So what exactly is the potential advantage of this 1940 laser? Since light at 1940 nanomicron wavelength is being more absorbed in water, the EVLA with 1940 with a radial fiber would require lesser lead and lesser energy per square centimeter of surface area of the vein. And as a result of that, there'll be less thermal damage to the vein. Because of this lower lead and resultant decreased optical penetration depth into the tissue, obviously there's a decreased thermal alteration of the perivenous structures. And this is very, very important because this will decrease the nerve damage, which we are always worried about, especially below the knee lasers for some of us who do that. And also peri-procedural pain is decreased and the complication rate overall are decreased. Now, one of the good studies reported on 1940 is one by Uldis Morens, who has done a large amount of work on this. So he reported about 100 cases of lasers using 1940 nanomicron over a period of 1 year. And he used only about 5 to 8 watts of energy during this study. And he found that as far as the closure rates was concerned in his study, at 10 days, there was a 100% closure rate, and even at 3 months, the closure rate was on 100%. Now, this is quite a good result, but when we use the 1470, we usually see at 3 months, there's about a 1 or 2% recanalization rate. Apart from that, the occlusive distance from the deep vein, because Dr. Uldis Moran goes right up to the junction of the superficial and the deep vein, at 10 days was 0.1 centimeter, at 90 days was 0.5 centimeters. The chance of E-hit was almost negligible. And even the venous clinical severity score went down significantly, 4.7 to 1.2. Not only that, if you see the resorption of the vein, that is the diameter of the vein when you do ultrasound later, he found that before EVA, the average size of the vein was 6 millimeters, 10 days later, it had gone down to 4 millimeters, and 3 months later, it was only just 2 millimeters. Having said that, in 1/3 of his patients, at 3 months, there was 100% resorption of the vein, which means that when you do a sonography at 3 months, there is no vein seen at all. So what he concluded was that when you use a 1940 laser, first of all, you can use a lower treatment power of around 8 watts, similar lead, no fiber carbonization. Now, this is a very, very important feature when you use a lower amount of energy. Because when carbonization occurs at the tip of the laser fiber and you keep pulling the laser fiber along the length of the vein, the amount of energy delivered towards the lower part of the vein is much lesser, obviously because of the carbonization. So there was no carbonization at all here, and this means that the amount of energy delivered was uniform along the entire length of the vein. And also, because you're using less amount of wattage, there's a chance that you can use very superficial veins, just like the anterior accessory great saphenous vein or non-truncal veins, which are very close to the skin. You can use this laser fiber for that. There was another study which was also published in the European Journal of Vascular and Endovascular Surgery on 1940 laser, and they also showed the similar results as for Dr. Moran's study. However, there are two sides to every story. Some may say 1940 works wonders, and others will say, really, is there really any benefit? And Lowell Koivnik showed us that when he did his study, which was published in 2015, and he concluded that the use of low endoluminal energy resulted in a lower vein occlusion rate compared to the 1470 laser. So when Dr. Woldis Moran says that my results were so good that at 3 months, 1/3 of the patients was fully resorbed, the occlusion rate was 100% almost at 10 days, and 100% at 3 months, Dr. Kabnik felt in his study that over a period of time, the occlusion rate was much lower when you use lower energy. And similarly, Mark Whiteley's study also in 2021 also said that although there is no great benefit of 1940 compared to 1470, the only advantage this may have is lower use of energy may help us in treating superficial veins more easily. So in conclusions, I would like to comment that as far as 1940 laser is concerned, I think there are still lots more studies to be done. No doubt, it is a good laser. The wavelength is good. It gives very, very good results. I would say as good as 1470, maybe sometimes better. But it's safe and effective. There are studies which show that lower post-operative pain, low analgesic requirement, short convalescence, and more patient comfort. So these may be some advantages. And finally, EVLA with 1940 nanomicron laser guided by intraoperative Doppler ultrasound permits reproducible placement of the radial fiber at the saphenofemoral and saphenopopliteal junction, if some of us want to do that, enabling a shorter stump, because we know that when a shorter stump is used, this decreases the frequency of recurrence without the increased risk of E-hit. Thank you very much.
We will discuss this. So, next speaker, Dr. Vimalin Samuel. He will speak about the future, the glue ablation.
Good morning, everyone, and thank you for the opportunity to give this talk. So today we'll be talking about something that we describe as a new kid on the block, and the question is this the future? So we have numerous aliases for glue. I like to call it glue. It's the easiest thing to say, but we can also call it a whole lot of other things: cyanoacrylate embolization, cyanoacrylate closure, non-thermal, non-tumescent ablation. Now, the mechanism by which it acts is basically when we inject, there's a rapid solidification, there's a polymerization reaction with the blood, and that causes clotting and inflammatory reaction of the vein wall, leading in fibrosis. So when we look at this, there's only mainly one company that is supplying glue in India. So the company says it does a reliable delivery, there's controlled polymerization, biological response, and all permanent occlusion. Now, this is what the company says. There's always a question. We heard Dr. Shoaib talk about something that has withstood the trial of time and something that is new. How does the old compare to new? We want to know the results. So when we look at first just the main advantages, there's no tumescence. So there's no, fewer needle pricks. There's only one actually, and then there's no thermal collateral injury, and the compression at the end is not, post-op is not mandatory. This is post-op compression, okay? And then, of course, we have to come to the evidence. Now, we've been having data from 2017 about glue, and most of them have been about 36 months follow-up, and there have been a few RCTs, but all of them have practically said the same thing. Then the week close trial, which is what has been published and has claimed results all over the world, is that at 36 months, we had 94.4% occlusion versus 91.9% occlusion compared to RFA, and stable improvement in quality of life. So this was the first randomized control trial that compared along with EVLA. So we see that the occlusion rates are almost the same. The main word, the key word here is non-inferior. That is what we are trying to establish. And we've seen that follow-up at up to 3 years, the occlusion rates are as much as EVLA and RFA. So it's safe and effective to use. Now, the problem happens is when we look at large size veins, that GSV up to 2 centimeters. A normal practice in India, we see a lot of veins that are 10 millimeters and above. So how is it useful for that? And of course the SSV. This is one study that we have that says, this is the WAVE study, that says that it's good for the SSV, the accessory saphenous vein, and up to large GSV. This occlusion rate was 98%. Again, the similar study published in Phlebology, it said GSV greater than 8 mm, there is some increased risk of recanalization on using glue. And when we have an increased GSV diameter, it's associated with a longer stump remnant, because when we do the glue procedure, we stay 5 centimeters away from the junction. Now, leaving behind such a big stump, having such large veins, does it translate into poorer quality of life post-ablation, post-using glue? We have studies that says that the VCSS and the quality of life improved significantly in all studies, and the recovery time and pain was much lesser after EVLA. So with any new procedure, there's a whole list of new complications that you can get with glue. And with glue, what we see most common is the phlebitis following the glue injection, because ultimately it is a foreign body that is going to remain within the vein. And there's some people are hypersensitive to glue. There's a swelling often, and then some people have developed granulomatous reaction because it is a chronic inflammatory response. DVT is about 3.5%. It's a controlled propulsion of the glue, so glue-induced thrombosis is about 1.4%. And then the other things that are common to both all ablative procedures. So in total, when we have a look at the whole process, we see that it is comparable to RF and EVLA. So the common excuse that everybody made was, where is the 5-year data? Because that is what we have for RF and EVL. And so this was published in 2020. This is the V-close trial follow-up. But if you actually go through the study, they've mainly concentrated on the demographics and the size of the patient and the size of the vein. And there is one slide in the whole study about, it's a Kaplan-Meier analysis about what the occlusion rates are, and they have said it is comparable to EVL and RF. So this is again 91.4, 85.2%. So in conclusion, we can say it's a safe alternative to thermal ablation. It's an office procedure. In our experience, we have done maybe about 30 to 40 of these patients. It can be done in an outpatient basis. One of the main cons of do this procedure is it requires 2 people to do the job, because there's one person has to apply compression while the other person injects the glue. And there's a bit of a learning curve that comes with using the gun that dispels the glue. And other than that, one of the main problems with using it regularly, what we find in our experience, is the cost of the process. So when we look at the results, they say that long-term results of more than 5 years is non-inferior to EVL and RF. So I think as of now, glue provides a good option for people who are a select group of patients who cannot undergo anesthesia. We see a large group of obese patients who may be rejected for anesthesia, or chronic venous ulcers, or people who are really worried about cosmetic results. Glue is a good option. Thank you so much.
Next, I would like to call Dr. Martinez, and he's going to talk about foam sclerotherapy.
Good morning, ladies and gentlemen. It's a great pleasure for me to give you this lecture called Sclerotherapy, Chemical Ablation, Is It Still an Option? I'm Hugo Martinez, and I'm a member of AFLEBOBASAL, which is the Phlebological Association of El Salvador. We are doing this job with the endovenous chemical ablation, catheter-directed, ultrasound-guided, using this long 30 centimeters catheter, 7 French, which we place at the point of the knee. We puncture the GSB and place the catheter until we get to the saphenofemoral junction. Once the catheter is in place, we infiltrate a local tumescent anesthesia to become this GSB very tiny, so we can get that size, almost the same size of the catheter. Once we have this, we start to pull over the catheter. As long as we are injecting polylocanal foam, we normally use 3% polylocanal foam, 0.1 millimeter of foam per every 1 millimeter of vein. Since we normally treat between 20 and 30 centimeters of vein, we normally use 2 to 3 cc's of polylocanal 3% foam to treat all the vein in the muscle. Once we have retrieved completely the catheter, we compress locally the size of the puncture, so we get anesthesia, and then we place these compression garments along all the pathway of the GSB, from the site of the puncture to the saphenofemoral junction. And after that, the patient is dressed with a compression stocking, 20 to 30 millimeters of mercury, and a compression bandage in the proximal third of the muscle. So the patient uses this compression for 24 hours. After 24 hours, the patient is authorized to withdraw the compression only to take a bath or to sleep. We encourage our patients to use the compression as long as they walk and as long as they sit, and we encourage them to walk. In this video, you can see how we place the tip of the central venous catheter in the saphenofemoral junction, and using ultrasound, we left the tip 1 or 2 centimeters below the saphenofemoral junction. If we have any doubt, we use normal saline solution to see where the tip of the catheter is. Normally, we use this method for patients who has an insufficiency of the GSB more than 1 second, affecting the terminal valve, and at least with 10 centimeters length, so we can place the catheter very near to the saphenofemoral junction, and with diameters between 5 and 12 millimeters, as described by the Latin American venous treatment guidelines. Beyond 12 millimeters, we normally use thermal ablation or open surgery to treat patients. 25 patients treated from August 2020 to July 2021. 15 of them completed the protocol, which is about chemical ablation the first day and 5 follow-ups. The first one at 1 week, at 2 weeks, at 1 month, at 3 months, and at 6 months. 17 GSB treated with a mean average age of 53 years old, with a time of follow-up average of 10 months. As you can see, the initial average diameter, the terminal valve and the preterminal valve, is 9 millimeters, and at 6 months, we find normally a diameter of 3.6 or 3.7 millimeters of diameter at the terminal valve and the preterminal valve, not a reduction of the diameter at 6 months. Patients describe the main symptom as pain in 2/3 of the patient, and the main sign as presence of varicose vein or active ulcer in 2/3 of the patients as well. Anatomical results, we found a reduction of 60% of mean diameter at terminal valve and pre-terminal valve of the GSB at 6 months. Despite venous flow was observed in 64% of our patients, reflux was only observed in 1 of the 17 GSB treated. Clinical improvement of symptoms in all patients was obtained and closure of 4 out of 5 ulcers at 6 months. As you can see, we normally measure the diameter of the GSB at the saphenophymal junction before the treatment. After the treatment, the spasm of the GSB is noticeable, and at 1 month and 3 months, we normally get this image as complete closure of the saphenophymal junction and respecting the flow at the common femoral vein. You can see the diameter diminished at 6 months. We normally have a partially occluded saphenophymal junction with flow at the terminal valve, but no reflux. Complications of the treatment were transient if there were present, but they were treated locally. Only we had 1 DVT that was treated ambulatory. Despite controversial anatomical results of the procedure, clinical results are quite outstanding, and patients are very happy with the procedure, as you can see in the images, and we as a medical team, we are very happy with the procedure as well. I invite you all to visit El Salvador, which is one of the few countries in the world where you can visit mountain and sea in the same day. Thank you.
So next speaker, Dr. Raul. He will speak on cryo laser ablation and cryosclerotherapy.
Good morning, everybody. Thank you, Deepak, and for organizing such a wonderful conference. I'm going to speak on aesthetic phlebology. I think it's a very important topic. At present, dermatologists haven't picked it up, and I do get requests from the dermatologists that they want to get trained in this procedure. And I think, vascular surgeons also are not picking it up at present because they feel it's a slightly different work, and it requires patience, and it looks very simple in the beginning. But the more you will keep on doing it, you will keep on learning that it requires also a skill set, anything like that. Because it's only in the skin. Really like to acknowledge all these guys. So they introduced me to this Clark's procedure or cosmetic phlebology around 4 years back. And 4 years back, we set up the department of Clark's and, all the cosmetic aesthetic phlebology department actually in the hospital. Hospital actually was not ready to set it up. And so I had to set it with my own money. But 4 years later, we are very happy with it because it took us some time to learn all, it's different things. I cannot cover in 8 minutes, but I'll just show you overview what we have learned in the last few years. So what we are talking about is the C1 stage of the SEEP. So this is what we are talking about. How do we treat this group of patients? And I'm not talking about this. So sometimes you have combinations of C1 and C2. So we always prefer to treat the C2 first. And, because sometimes there is a pressure from the C2 venous disease, and you follow these patients up in 2 to 3 months, and a lot of C1 disease goes off. And if the patient does not want any further cosmetic treatment, then we don't touch the C1 veins. Now, C1 is mainly because of cosmetics. So that's what we started when I started the practice, because I learned in Brazil, and all they were for beautiful legs, nothing else. And over a period of time, I realized that in India, there are less patients of beautiful legs, but there are more patients where we can treat these patients. I'll tell you what. So there are two types of veins you have to understand. One is the reticular veins, the blue color veins, what you can see over here, and they are like 1 to 3 millimeters. And please pay an attention to the below diagram. You have to understand, first the veins are blue, and then when they branch out, they become slightly lesser blue, what we call as telangiectasias, and then they also become red. So on the skin, you will see sometimes the blue, sometimes red veins. So it goes from the main vein, they keep on getting smaller and smaller, and the smallest vein, they will be red in color. Now it's important because the more red they are in color, the more oxyglobin is present. The more blue, the deoxyglobin is present. So that's what it is important, because that's how the laser works on the basis of hemoglobin concentrations. Now there are various ways to treat these veins. So you can, I have mentioned, few of the options, and now which is the best option available, we really don't have an answer. So even if you look into the last year's publication of European Society of Cosmetic Phlebology, there is no clear-cut answers. So you can use multiple options for the treatment of these veins. So why not only use sclerosant? You see, the sclerosant drawbacks are basically, one is the reactions to the sclerosant. Second is we cannot control it. Like if you want to do a vein on the face, you can't inject sclerosant because you cannot control sclerosant. It will just flow. Anyway, it can hurt the eyes, it can close the septums. Next is the skin damage, because if you inject slightly more, how do you know how much to inject? So you cannot have a fixed concentration. So you will have some complications. If you treat 100 patients, you will have 5 or 6 patients where you will have a cutaneous necrosis. The next is a pigmentation, which is, can take really 6 months to 1 year to 2 years for the pigmentation to go. So if you're doing it for cosmetic purpose, it's not very good. So Clark's means, so you do basically 3 important things in this. You do a transdermal laser with a sclerotherapy. You do use a cool layer because it hurts. And you use an augmented reality because you cannot put your hand inside and then do it, because it's not possible. So this is our setup, outpatient setup, which we have put in. We put in an ND-Vike laser. It's better to buy this platform, because this platform now is being used by the plastic surgeons also. So we do tattoo removals, hair removals, all the other things what we can use by the other specialties. And you can use the same machine for your aesthetic phlebology. You can use a very cheap, around 7,000 to 8,000 rupees thing like this, or you can use a vein viewer which costs around 5 lakhs. So, depending upon how fancy you want to go and how clear you want to go. You have to understand why do we use an ND-Vike laser and how do we make it. ND-Vike laser is a solid laser, and the solid component in this is yttrium aluminum garnet. And you got a chemical agent in this, what we got neodymium. So as soon as you put in this active medium in this tube and you put in a current, the atoms goes up and then they give you various wavelengths. Now, ND-Vike can give you various wavelengths, which I mentioned over there. So then you can select what wavelength you want. And with various studies, it has been found that 1064 is one of the best lasers which can help us. So if you look into this chart, you see the infrared, like, the red light and infrared. So ND-Vike is a part of an infrared. So it's a mid-infrared rays, which is very good. And there are various advantages, because it's a longer wavelength, so it can go much deeper. A better absorption in deoxyhemoglobin. So if you want to treat these blue lines, it really works very well. And very low power consumptions. So as it doesn't hurt the epidermis, as you know, the melanin is present in the stratums, from the bottom. And so it does not hurt the epidermis, so your chances of epidermal necrosis becomes very, very low. So let's take up 1 or 2 patients here. So look at these veins. Now, you can do phlebectomies here, you can do plain foam sclerotherapy, and especially in the foot veins. Look into the left picture, there are a huge amount of foot veins, and people, the ladies, they come that you got a very prominent foot veins here, you got foot perforator incompetence, rest of all the veins are normal. So if you put in a sclerosant very high amount, then really you're always chance of getting a small vessel, the venous peroneal or posterior tibial vein thrombosis if you inject directly, or it can very high chances of skin necrosis because if you use a dilute sclerosant, then the recurrence is very high. So we have tried all those stuff. So these things, they really work in the veins which are very, very close to the skin. I'll just put in this video. How does it do? We are using a coolant. We are using this NDY laser. So we can use a 6 mm spot. And because that goes very deep. Don't use a 2 mm spot because that really burns the skin. And once you have done this, and then you can, under the vein viewer, you can inject a sclerosant. What sclerosant? You can decide. You want to use dextrose, you want to use 0.25 STD or polydocanol. And once you have done this, you see the results. Like the legs are very clean. So no phlebectomy can give you these results. Plain foam sclerotherapy does not give you these results, as you must have seen in your practice. Now these are the results we want. All that blue color lines, cosmetic. This is all cosmetic now. The results, what we are looking for. Spider veins, really. Now, looking at the pictures, it looks very simple. But mind you, this thing, achieving this result, it really takes time. It requires a lot of patience. You can actually do 4 EVLTs during this time. So it takes time, really. When I have to do this case, I really have to cool down from the arterial cases to coming just into the epidermis. And it's really, you have to have a different mindset to do this. Now, you can actually get this type of results very nicely. You can never get, I'll show you some pictures, very nice. So look at this. Very superficial C2 veins, reticular veins, some C1, and there is a skin necrosis. There is a small pigmentation. So this will happen in some of your patients, everybody. Look into this. Did we did a Clark's or a microfoam? So we did a combination. And you can see wherever I have got this pigmentation left over, that is because of the foam, which we injected, a dilute foam. This will get lighter in 6 months, but there is there. So this was a combination of Clark's and plain foam, 2 sittings, but it really takes a lot of time. So foot veins can give you very good results. And look into this foot veins, we can get fantastic results here. This is a man with a really troubled foot veins. As you know, there is no perforators. It's just a cosmetic, that small blush of veins on the foot, and which gives a really nice results. This guy was rejected from the army for that small little bit vein. So you can inject a sclerosant into it very easily. But that pigmentation requires time. So here, within a month's time, you can get much better results here. This another doctor, she had a very prominent facial vein here. You cannot use sclerosant. So we just used only plain laser. You can use the machine. I'm just putting in the uses where you can use it. So if you look into the published results, even the Clark's procedure is not 100% successful. So there is a failure. So we have also observed in our setup that if you just do plain Clark's, if you do 4 or 5 areas, there will be a recurrence of the veins there. And this is one of the largest studies published, 577 patients. And you can see the chances of pigmentation, which is very important, skin burn, and the matting is very, very low. It's nearly under 1%. So that's the beauty of using combination of Clark's and this. So what's the drawbacks? Cannot be everything good. I have already showed you. So there is a learning curve, definitely, and it's not painless. And a lot of our patients, they really cry in pain. So we have started using local anesthetic creams and make them wait, and then you have to clean it up or use the lesser laser settings with the repeated laser courses. It's an expensive setup. It's not cheap. It will cost you somewhere around 80 to 90 lakhs. And if we have to do the whole leg, means the whole day is gone. Okay? So it really takes time because it's very, very slow. So what we do is, whatever the most prominent area the patient is worried about, we do the Clark's. and we combine it with a plain diluted sclerosant in the other areas. So, this is what we have learned. Now, in future directions, we should compare the study. There is no comparative study head-to-head. Because as you know, the C1 veins are of different types. So there are 3 studies on underway. So we should be able to get the results this year, comparison of exactly Clark's and plain sclerotherapy. Because sometimes I feel there are some patients where 0.25 polydocanol gives you also the similar results in some patients. But I cannot predict, because some patients, it causes pigmentation. So I don't have a control on what the patient will get. Second is, different sclerosants like STD or polydocanol, they should be compared, which is very important. And I feel that in the future, the Clark's needs a bit more clearance and the places where it can be used. I feel the foot veins, the facial veins, hand veins, and in very patients who are very sensitive to pigmentation, it should be used. Thank you.
Thank you, Rahul.
Next, Dr. Sheglo is going to talk about phleboarthrosis.
Dear colleagues, ladies and gentlemen, thank you very much for the beautiful possibility to participate in your conference. Several words about me. My name is Ernest Sheglov. I am professor in the Petrozavodsk State University. Petrozavodsk is a small city nearby St. Petersburg, nearby the Finland border. I am working on the problem of phleboarthrosis for more than 15 years, and I have a lot of patients. And I am very, very glad to discuss you and to describe you some of my results. You see that phleboarthrosis is a very huge problem, and the last time we were speaking about it in different journals, as in Russia, as in the international journals. I want to talk about its treatment. You see that in the United States, we can see that in 1918, the last guideline for the management of the osteoarthritis of the hand, hip, and knee. It's the last reduction of this guideline. And what we can see here, the knee arthrosis. We can see that the most important drugs are oral non-steroid anti-inflammatory drugs and topical non-steroid anti-inflammatory drugs, which are strongly recommended. I don't know the situation in India, but I know that in Russia the most important drugs are glucosamine and chondroitin. And in the United States you can see that these are strongly against using these drugs for knee phleboarthrosis. We can see oral and topical non-steroid drugs are most important, and other drugs are strongly recommended or recommended against. We can see that the non-steroid topical anti-inflammatory drugs are the most important, but their doses should be as low as possible, and the treatment should be continued for as short time as possible. Also we can say that these drugs are a very, very important part of the knee osteoarthritis treatment, but we must use them as short time as possible and in the lowest possible dose. So, we must welcome any drug or any method that can reduce the non-steroid anti-inflammatory drug dose or the duration of treatment. The purpose of my investigation was to evaluate the influence of venous therapy on phleboarthrosis patients' need for non-steroid anti-inflammatory drug. The main principle of the investigation was that we have a group of patients with knee phleboarthrosis. That was a combination of varicosity and knee arthrosis, osteoarthritis, but we have no varicosity. These patients had no varicosity treatment before our investigation. What we do? We have no changes in arthrosis treatment. The same treatment as it was before the investigation. The same drugs, the same physical rehabilitation, no changes in the arthrosis treatment. But we use micronized purified flavonoid fraction and compression stockings for these patients. And we evaluate the influence of this treatment on the need for non-steroid anti-inflammatory drugs for these patients. The clinical group was 105 patients, the control group 37 patients. The diagnosis was confirmed by X-ray and ultrasound, no varicose treatment before, and the evaluation before treatment 6 and 12 months after the beginning of investigation. The clinical group received regimen recommendations, compression stockings with a pressure between 20 and 30 millimeters, and micronized purified flavonoid fraction once a day. Control group, the same treatment as it was before the investigation, the treatment only osteoarthritis without varicosity treatment. The results. We evaluated the patient's need for non-steroid anti-inflammatory drugs, but we can't evaluate the exact dose of the drug because the patient used the different drugs before the investigation. So we used the survey with the possible answers. The need for non-steroid anti-inflammatory drugs has decreased strongly, has decreased, the need without changes, and the need has increased. What results we received? The clinical groups, they reported that 79% of the patients decreased the need for anti-inflammatory drugs. Strongly decreased 12%, and without changes 9%. The control group, without changes 86%, decreased 8%, and increased the need for anti-inflammatory drugs 6%. That's why we made this conclusions that when active therapy reduces chronic vein insufficiency symptoms and decreases the need for non-steroid anti-inflammatory drugs in patients with knee phlebitis. This therapy must include compression stockings and micronized flavonoid fraction. Now we have more than 15 years of investigations, more than 1,000 patients with knee phlebitis. I will be glad to discuss the problems of pathogenesis, diagnosis, treatment of this disease. For example, I think that the very important question is the question of the hen, the chicken, and the egg. Varicosity leads to knee arthrosis, or knee osteoarthritis leads to varicosity. I think that I have the answer on this question. Thank you very much for the possibility to participate in your very interesting conference. My email is on this slide, and I will be very glad to answer the question or to discuss any problem with all my colleagues from India. Thank you very much. Best wishes. Bye.
Next presentation, the topic microwave ablation and its clinical outcomes. The presenter, Dr. Motsas.
Respected colleagues, ladies and gentlemen, good morning. My name is Matjaž Vrtovec. I'm interventional radiologist from University Clinical Center Ljubljana, Slovenia. I'm honored to present at this distinguished VACON 2022 meeting. I will talk about our initial experience with microwave endovenous ablation technology. Microwave endovenous ablative technology is relatively new, not mainstream and not very known. It is more niche or still exotic modality as HIFU. It is thermal ablative method and it requires use of tumescent anesthesia where done. Of course, every interventional radiologist, phlebotomist, or vascular surgeon has its preferred endovenous modality. In reality, to achieve optimal result, the best is to use modality which addresses best anatomical, constitutional, and functional specialties of the patient. Microwave part of electromagnetic frequency spectrum is stretching between 1 and 300 gigahertz. Microwave field, when applied to tissues, causes water molecules to rotate very fast, and friction produces heat. In theory, microwave technology should have bigger and more homogeneous volume of ablation and should be less dependable of thermal conductance of tissue around the active probe tip. It does not need electrical conductivity of the tissue to produce heat. Ablative efficiency, especially when tissue immediately around probe tip becomes more dry during ablation, can affect the ablating efficiency. Literature about microwave endovenous ablation and about comparison to other modalities is not very vast. If we try to draw some modality comparison from their use in the field of oncology, microwave ablation should offer less peri-procedural pain, larger and more predictable ablation volume, and in theory, this should result in more consistent ablative effect. In our institution, we use microwave system produced by Ecomedical Instruments, China. It consists of dedicated microwave generator unit and disposable, soft tip, flexible, not sterilizable microwave probe. When introducing probe into the vein, 7 French introducer sheet is needed. Maneuverability of the probe in the vein is good. The probe has blunt soft tip and can be successfully steered also through slightly tortuous veins. Probe active tip measures 2.5 centimeters and is very well visible at ultrasound, as you see on screen. About our series, we included patients older than 18 years with saphenofemoral opening measuring less than 10 millimeters and venous disease graded C2 to C5. Patients with active cancer or infective disease and also pregnant women were excluded from the series. Patients with past DVT or recurrent varicose veins were not excluded. Ablative modality, microwave modality, was chosen randomly. We started with the first microwave procedure almost exactly 1 year ago. Till 10 days ago, we performed 42 microwave procedures on 42 veins and 42 patients. Majority of treated veins were great saphenous veins. Initially, we used ablative protocol as suggested by manufacturer, that is 40 watts for 7 seconds per segment. Ultrasound follow-up was planned at 3, 6 and 12 months post-procedure. Because of not very favorable first results or technical outcome when using 40 watts protocol, we recently changed ablative protocol, upgraded it to 50 watts per segment. Presence of edema, pain, cramps was also evaluated. Patients filled out civic questionnaire, but those data was not yet included in our results. Till 10 days ago, we controlled 26 limbs on 26 patients. After initial 40 watts protocol, 13 patients were controlled at least 3 months after ablation. 5 of them, that's 38%, presented with completely closed vein. In 4 patients, ablated vein was still open but showed no reflux. 1 patient had partly opened, partially insufficient vein, and in 3 patients, that's 23% of them, ablated vein remained open and also insufficient. In patients controlled 6 and 12 months after the 40 watt protocol, the number of patients controlled was 9. Only 1 patient was controlled after 1 year after the procedure. Of those patients, in 6 or 60%, ablated vein was still open and still insufficient. In the other 5 patients, in the other 4 patients, or 40%, ablated vein was successfully closed. After changing the protocol to 50 watts, only 3 patients were controlled till now after 3 months post-operative. So no realistic statistical comparison can be done yet, but nevertheless, no still open or insufficient vein was noted. 2 treated veins were completely closed and 1 partly closed, but clinically none of the controlled patient was symptomatic anymore. No edema and no pain or cramps were present. So we can probably conclude that microwave technology has a good safety profile, is well tolerated by patients, but actual by manufacturer recommended ablative energy is probably too low to achieve favorable result. Corrected, higher 50 watts energy protocol might prove optimal result. Connection between vein diameter and successful ablation is quite probable. Thank you for your attention.
Thank you. Now we'll start the discussion. Anybody from the audience would you like to? Yes.
Hi.
Yes,
This question is for Rahul, if he's around.
Yeah.
Yeah. Hi. Rahul, so for CLACs, I think one of the challenges with cutaneous or transcutaneous lasers has always been how safe it is in darker skinned people. So I just want to know what your experience has been with using in the darker skin, and you get more cutaneous burns in that?
Yeah, fortunately, North India. So we don't, as you know, there are 6 second grades, and normally most of the skin what we have treated, they are grade 4, grade 3. And so we hardly get any patients with 5 and 6. But if you look into Brazil, they do get a lot of patients at 5 and 6, and you just need to lower the energy. And so you can do it, there's no problem. But you just have to lower the energy, that's it. Because you see, most of the skin, this anti-VAG will go deeper into the deeper dermis, and so it will not affect the epidermis. So unless you use a smaller diameter shot, like so we use a 6 mm spot, so which will cross the epidermis, and so it will not get absorbed by the melanocytes. So even if you have a darker skin, it will not affect. So, but yes, definitely you need to lower the energy if you have higher, and if you have to increase the energy if you have a whiter skin.
Yeah. I think this is something that probably those of us who practice in South India and maybe other parts of the world need to be very aware of. And unfortunately, it doesn't always come up in the Western literature and the Western discussions.
Absolutely.
So we can get misled on that. But
no.
Thanks for bringing up those finer nuances.
This is the basics of when you do an anti-VAG laser, any skin laser actually, and that you need to know the type of skin. So the first thing, if you look into the protocols published by any company or anything, is the first thing what you do is the type. And then you go for the doses. But it's a very important point for the people who are very, who are just doing the beginning.
Right. One more follow-up.
Yeah, please do.
So this is to Dr. Matej. I mean, fantastic presentation, and congratulations for the honesty of what you've shown. It's not very often that people are willing to show the results which were not quite up to what they would expect. But seeing what your results are with microwave, where do you think its position lies today, given that you have, in a sense, better established technology like RF and laser?
No, you're not audible.
Maybe once he's back.
He's not.
So this is more of a comment than a question. If you see amongst all the presentations that were made, the results are basically based on what the initial diameter of the veins were and what the final diameters of the veins were later. So I would like to ask members of this audience and the panelists, what do you take as the diameter in which position of the patient? Are we keeping a standard 45% inclination of ultrasound of the patient while taking the diameter of the GSV? Are we taking it in a standing position, or is it in a supine position? In all 3 different positions, the diameter of the vein is grossly different. So there has to be some standardized protocol, at least in our association amongst our members, where we measure veins. Most of the radiologists, when they give a report, they do that in a supine position. There are two problems with this. One is in the supine position, the vein diameter is much lesser. Secondly, many a times you will never get reflux in the supine position. And therefore, when the patient stands up, there are no varicose veins. When he goes to the radiologist center, the patient is lying down, there are no varicose veins seen, and the results of the radiologist is this is normal venous dominal study. So I think we should come to a protocol. I know it's very difficult for us to have a patient in standing position, but at least if 45% inclination is done, that should be the standardized protocol for ultrasound in all our patients, and also as far as procedure, diameter of the venous concerned, like the opinion of the Apollo.
Pinjal, any comment, Pinjala?
I will pass. Absolutely very good point. And we, when we started including all our patients into the study, so this was the basic problem we had. So because how to measure in the standing position the pre-op, and sometimes you are in on the outpatient, the people will take the patients on table. Then we went through the research and found that there are a lot of studies which have taken the diameter as a standardized in the lying down position at the 45 degrees. So that then we standardize all our protocol that all the measurements we will do will be at 45 in a standing position, 10 centimeter below the septum-femoral junction. Because and this is, there are a lot of papers on that. Because you should not measure at SFA or 2 centimeter because sometimes that is very dilated and the rest of the vein is approximately 8 to 10 millimeters and you could have a 14 millimeter, 15 millimeter at SFA. So, if you are doing any studies, I think you can, what we do in our practice now, when we are collecting all data, so we have standardized that, and we have found that below, near this, sometimes the vein is very small, SFJ is very big sometimes, so around 10 centimeter below the SFJ, there's a very nice place, is reported. But we can standardize everybody.
The protocol which we follow and which we discussed last time in the Asian Venous Forum was this. Size of the GSV at the terminal junction, terminal valve. I mean, when I say that, it means at the junction of the superficial and the deep vein, number one. Size of the GSV 2 centimeters away from that, because most of the time when you're doing ablation, that's when you're ablating it. Thirdly, in the mid-thigh, not a particular level of so many centimeters, because size of the thigh will differ in different people, from the knee joint to the groin, mid-thigh. The reason for this is that many times mid-thigh perforator is just at this particular level and size of GSV below that is much higher. Then 2 centimeters below the knee joint, because again there is a below knee perforator which sometimes goes into the GSV and causes dilatation of the vein. And then 2 centimeters above the ankle joint, again for the simple reason that sometimes there is a mid-ankle perforator, mid-leg perforator and above ankle perforator. So in each individual patient, if you take these as their standard diameters, then you'll have a proper diameter setting. Now this is a suggestion, but I think VI should take this up and make a formal protocol so all our members will follow this.
Thank you so much. We'll have to halt the discussion here. Once again, thank you to all our panelists, our speakers. A special thanks to Dr. Matt Jas for joining us throughout, and he's joined us virtually. We are glad that he stayed through the session. Thank you to our chairperson, and thank you to our panelists once again.